Dear friends and colleagues, welcome to the wrap-up of the Thoraxcenter of the ACC meeting in Washington, D.C. My name is Nicolas from Mieghem, and as always, it's my great pleasure to have Joost, Daemen, my good friend and colleague, to do this wrap-up together. Joost, I think one of the important trials was the Pacman AMI.
Absolutely. So Pacman AMI is the multi-center international randomized controlled trial led by our friend and colleague Laurens Reber from the Inselspital in Bern. So the study actually randomized a total of 300 AMI patients to either rosuvastatin or rosuvastatin 20 topped off with Alirocumab, the PCSK9 inhibitor of Sanofi, to look at a primary endpoint of plaque reduction. So in all these patients directly post-MI, 2 non-culprit vessels were imaged with multimodality imaging using OCT and NIRS-IVUS and then reassessed at 1 year. And what the trial showed is that the primary endpoint demonstrated a significant reduction of percent atheroma volume in both arms, but in favor of the Alirocumab arm with a absolute delta of around 1%. So more plaque reduction when Alirocumab was added to rosuvastatin 20. Driven by a LDL reduction of around 50% in the rosuvastatin arm as compared to 85% in the rosuvastatin plus Alirocumab arm. Additionally, the trial demonstrated also not only plaque regression but also plaque stabilization with a decrease in the max LCBI in the vessels of interest in favor of the PCSK9 inhibitor group, but also an increase in minimal fibrous cap thickness as assessed by OCT, illustrating the fact that this add-on of Alirocumab really also took care of further plaque stabilization in these patients post-MI. That resulted also, of course, the trial was not powered for that, in a significant reduction in non-target vessel revascularizations. And that could be theoretically, looking into the future, interesting, 8 versus 18%. Obviously, small study, not designed to study this, but it was an interesting observation that is really in line with the more intense lipid-lowering therapy plus plaque stabilization and regression in the Alirocumab arm. So interesting concept.
Yeah. But although a relatively small sample size, this was published in JAMA, and rightfully so. I think the design was really on par. You also co-authored on this. I think one of the major takeaways for me, at least, is that this plaque reduction was minimal. We're talking about 1%, but I think this stabilization and the plaque remodeling, that is the clear novelty, at least for me as a non-super expert in invasive imaging. And I think this thickening of this fibrous cap, that really endorses stabilization of the plaque, and you have less vulnerable plaques, basically, right?
To me, one of the key takeaways is the fact that this trial once more illustrates that more aggressive lipid-lowering therapy in general is the way to go in patients post-MI. Of course, the plaques in the non-culprit vessel will not fade away over time, but the fact is, typically they would only grow, and now they stabilize. And whether or not they stabilize, remain the same, or decrease 1%, I think is not the most critical finding. But the fact is that we really need to be, as a community, really on top of adding high-intensity lipid-lowering therapy.
Favorable remodeling. The next study.
Good. VALOR.
Yeah. So VALOR or VALOR-HCM studied Mavacamten, which is an endosin inhibitor, basically a negative inotropic drug in patients with hypertrophic cardiomyopathy. This was a small study, also a proof of concept, if you will. 100 patients were randomized in 20 US centers, and then at 16 weeks, patients were evaluated for their symptoms, but also echocardiographically. Turns out that at 16 weeks, so only 4 months, only 18% of the patients who had a formal indication for septum reduction therapy, either surgery or alcohol ablation, only 18% of those patients in the Mavacamten arm remained with a formal indication for an intervention. Whereas in the control arm, 76% of those patients remained with that indication. I think this is quite a remarkable finding after only 4 months of study follow-up. I think we'll see. I think more important will be the long-term follow-up, and we learned that patient follow-up will take all the way to 128 weeks, and I think that will probably give us more robust data, but I think this is quite promising, and offers a less invasive, let's say non-invasive alternative for patients with hypertrophic cardiomyopathy.
Yeah, I agree. It's interesting, negative inotropic drug. So I would expect that, of course, if this works, you need to keep on taking this forever.
Yeah.
I'm not sure how well it is tolerated. What happened to patient symptoms? Apparently, most of them actually only improved in terms of quality of life. So no, I think it's an interesting concept and something that will have a role in future practice.
Yeah. Next on,
more on drugs is the EDIT-CMD trial. So this is the small multi-center randomized controlled trial from the Netherlands actually, in which a total of 85 patients were studied and randomized to either DIL-TSM or placebo. So patients were studied in case they presented with stable angina but had no objective signs of obstructive epicardial coronary artery disease, but did have signs of microvascular dysfunction, defined as, I believe, a CFR above 2. Or below 2 and the IMR above 25. And only then they were randomized to either DIL-TSM or placebo and reassessed at 6 weeks. Guess what? At 6 weeks, no statistically significant differences in the DIL-TSM versus placebo arm. So actually a completely negative study. In fact, the CFR only increased in the placebo group, whereas it decreased in the DIL-TSM group, which I found a little bit odd. Whereas IMR remained completely unchanged. So yeah, a little bit of a bummer to me. I think the study concept was interesting. There are a lot of patients who present with stable angina and no obstructive signs of no signs of obstructive epicardial disease. So it's a frequently encountered problem for which there are no proven therapies, unless items like DIL-TSM.
Well, so I think it's important in a way that it questions common practice, because when we face patients with microvascular dysfunction, this is what we do. We prescribe calcium antagonists. But to me, this microvascular dysfunction topic still is part of a black box. You know, it's like diastolic heart failure. Yeah.
It is.
Also this, what is it? Is it a real entity, and the effects of placebo are quite significant? Yeah. And then the moment you start studying it in a randomized control trial, you open up a different door, and then it turns out to be an empty box. So.
No, I absolutely agree. I think there's still a lot to learn on microvascular dysfunction, the combination with diastolic dysfunction, pulse pressure, aging, etc. In a study, and that I found a little bit of a downside, is there was very little, if actually no data on how blood pressure was managed. There was no data. I mean, the percentage of patients on beta blockers was only 30%. So I think there are some things to say, but with that, I think we have to keep on studying this topic, and in that respect, I like the study.
Kudos to our colleagues in Mieghem for doing this study, for sure.
Yep.
PROMPT-HF, heart failure study where they looked at an algorithm where physicians would receive alerts to improve guideline-directed medical therapy. More than 1,000 patients in the United States were followed by 100 caregivers. And 50 of those caregivers received alerts and 50 did not. And then they looked at the percentage of guideline-directed medical therapy of their patients. Turned out that there was an increase of 25% in the group where alerts were given to the caregivers versus a 19% in the control arm. Okay, alerts will improve or will increase the uptake of guideline-directed therapy, but I'm not so impressed by this study. Although it was published in JACC, I think you need to enter the dialogue with your patients to improve therapy compliance. I think that is much more important than receiving alerts on your phone as a caregiver.
Yeah, I agree. On the one hand, on the other hand, I mean, that's what I learned from all the hypertension trials I was involved in. Managing blood pressure is per se maybe not so difficult, but if we look at the patients in our own practice, only 50% is on target. And that is partly because patients do not take their drugs, but also largely because we as physicians are simply not that aggressive in prescribing the guideline recommended therapy. So if these digital monitoring apps could help you, it's sad, it's needed. But what
do you think? That the physician doesn't know, or they're not willing? And if they don't know, then
it's inertia.
Okay, but do you think you can change inertia in a durable fashion by giving alerts, I don't think so.
No, I agree, and you can imagine at some point this gets annoying, but
you will turn off the alerts. You will turn off the alerts. Okay, FAME3.
FAME3. FAME3, you guys all know it was the blockbuster presented at TCT last year, the randomized controlled non-inferiority trial comparing contemporary PCI with FFR in patients with multivessel disease as compared to contemporary CABG. The trial missed its primary endpoint of demonstrating non-inferiority due to higher TVR and MI rates in the PCI arm. And now this year at ACC, Bill Fearon presented the quality of life figures. Interestingly, guess what? PCI patients recovered faster. However, at 1 year, in which again, as compared to baseline, EQ5D and CCS classes were measured, no statistically significant difference. So the EQ5D sum score, as well as the number of patients with CCS class 2 or higher, was statistically similar in both arms. Of interest, one interesting observation is that the percentage of patients that went back to work within 1 year, below the age of 65, so the working age group, was statistically significantly higher in the PCI cohort as compared to the CABG cohort. So that said, I think this data confirms previous data on PCI versus CABG and quality of life, maybe an earlier recovery after PCI, but at 1 year, no longer a difference between both treatment strategies.
Yeah, that's a universal theme, I think. Less invasive strategies will improve quality of life faster.
Absolutely.
And at one point there is a catch-up. No surprises there. I think we should not overcredit the FAME3 and make no mistake, I think the investigators of FAME3 are really expert people. They're pioneers in coronary physiology. But I would not want to overstate the importance of FAME3. Why? Because the PCI arm was not contemporary PCI. Only 12% of the patients received invasive imaging guided PCI, and let's face it, that is the way to go in this day and age. If you do not do invasive imaging, you cannot compare yourself to surgery, in my opinion.
That is obviously a limitation that should be addressed to FAME3. Conversely, I think if you look at the amount of patients with CCS class 2 or higher at 1 year, was 6 versus 3%. And I think that attests to the fact that the quality of care in general is improving. And this I think is quite good. There's a lot of data showing us that up to 20% of patients post-PCI still have significant angina. So I think this, for what it's worth, is to me a perhaps interesting observation.
Flavor.
More on IVUS and the potential impact of IVUS in a PCI practice was addressed in the FLAVOR trial. So FLAVOR was a multinational collaboration between Korea and China, in which a group of investigators randomized over 1,600 patients with intermediate coronary artery lesions to either IVUS or FFR. So one-to-one randomization, FFR below 0.8, or IVUS in case of a MLA between 3 and 4 and a plaque burden above 70, or a MLA below 3 square millimeters. Guess what? What also was done is a post-PCI optimization that I actually didn't know up front. So that to me was quite interesting. There was this optimization threshold of FFR 0.88, meaning a definition of optimal PCI as defined by FFR. And also with IVUS, operators needed to at least they had to pursue a MLA of at least 5.5 or a area stenosis that superseded the distal reference. So that I liked a lot. So as expected, provocative findings. First, a confirmation of the old adagium. If you want to stent, do an IVUS. If you don't want to stent, do FFR. And that was really nicely reflected in the percentage of patients that actually underwent treatment for this intermediate lesion. So in the PCI arm, 65%, whereas in the IVUS arm, 65% was deferred from treatment, or 56% was deferred from treatment. So in the FFR arm. So treatment percentage of 65 versus 44%, so a statistically significant difference. However, if we look at the primary endpoint, a composite patient-oriented endpoint at 2-year completely overlapping event curves. So this, I think, was at least to me interesting. Also, with respect to Seattle angina scores, no difference at 1 year. Some subgroups in the secondary endpoint demonstrated that in PCI patients, a trend was observed towards lower event rates in those that actually underwent IVUS-guided treatment. But that said, I think an interesting study with a provocative study hypothesis that was also criticized by the fact that, these technologies, at least in my perspective, should be seen as synergistic technologies and not necessarily competitive technologies. You do FFR if you want to define the physiological significance of a lesion. And if it's positive and you want to treat, you use IVUS to do your treatment. I think that is the concept that is probably the way to go towards the future. Conversely, if you have to choose, using FFR is probably a very safe technology to decrease the number of PCIs and maybe get similar outcomes in this relatively lower risk patient population with intermediate lesions.
So, 2 comments. I think we all know how difficult it sometimes is to achieve a post-PCI FFR above 0.88. Yep. Sometimes it's virtually impossible.
Absolutely.
So that is one thing. So I don't think that coronary physiology will be the driver for a post-PCI optimization. Then second, and to my previous point on FAME3, I think the importance of invasive imaging cannot be understated. You do see a signal here towards lower event rates. And we all know from Greg Stone in the past that the annual event rate after a PCI is 1 to 2% every year again. Yep. And we are now talking at an endpoint at 2 years. Well, let's see what happens at 5 years. It could be that the curves will start to diverge. Yep. So I'm getting more and more convinced that if you do not do IVUS, then you're not performing the optimal PCI, especially not in more complex cases. So that's also where this CHIP IVUS comes in, a randomized controlled trial where we are randomizing patients to IVUS-guided versus angio-guided PCI of more complex lesions. And I think, more and more the literature is building on the importance of imaging, and I think rightfully so.
Yeah, that's a fact. There are numerous randomized controlled imaging trials on the way, whereas there's a lot more debate as to the superiority of FFR versus angio nowadays. Yeah. So I think there will be a lot of interesting data to look out for in the upcoming decade. So more to come on imaging versus physiology.
And it also underscores that it really remains very important for physicians and researchers to focus on this topic of coronary physiology, because this is not solved yet. Definitely.
Absolutely. Not. Partita.
Yeah, Partita, we're moving now to the EP world, EP and heart failure. Partita, I think, was a very interesting study in patients who had an ischemic cardiomyopathy and had an ICD. Yep. 2 phases. In the phase 1 that enrolled more than 500 patients, they looked at the time to first defibrillation, so to first appropriate ICD shock. Patients could have anti-tachy pacing or whatnot. That was okay, but the moment they got appropriate shock, then they were randomized and entered phase 2, randomizing patients to either immediate VT ablation or control, medical optimization, and so on. Turns out that only 56 of more than 500 patients, I think 517 patients, entered phase 2. So only 56 of those patients received an appropriate shock, meaning that these patients were properly treated, but also that tachy-pacing works. Anti-tachy-pacing definitely works. But physicians need to be on target, because once there is an appropriate shock, you make a difference with VT ablation in terms of less hospitalizations. And if you then look at mortality, there was 0 mortality in the treatment arm, but very small number of patients, and there was mortality in the control arm. So I think the conclusion of the Partita investigators was that you really need to apply good algorithms, ICD algorithms for anti-tachy pacing, but also the moment there is an appropriate shock, you really need to consider VT ablation. It is a little bit more aggressive strategy, but I think electrophysiology has evolved and matured, and I think VT ablation should become more and more standard of care in patients with appropriate shock.
Yeah, I couldn't agree more.
Yeah.
TAVI.
Yeah, so an important study that resonated well during ACC was this study that was presented by Michael Reardon and the investigators of the US pivotal core valve study and SURTAVI. So both trials were combined. Also, additional registries were added to add patients. And then they looked at structural valve degeneration, comparing surgery with TAVI with the supraannular functioning self-expanding valve. So an early generation core valve, the predecessor of the Evolut Pro Plus that we are applying these days in our practice. I think the results were quite important because up to this point, we knew from Partner 2, which evaluated the second generation balloon expandable sapien valve, that structural valve degeneration tended to be more common with TAVI than after surgery at 5 years. Here we see the total opposite phenomenon. We see structural valve degeneration in approximately 5% of the patients, 4 to 5% of the patients after surgery, versus 2 to 2.5% after TAVI. And that was a significant reduction in favor of TAVI. Also, patients who had structural valve degeneration had more events and their survival at 5 years was lower than patients who did not have structural valve degeneration. So I think this is an important finding, also reassuring for the TAVI space in general. So that was this final conclusion by Michael Reardon, by the way, who is a surgeon, who said, well, you no longer can claim as a surgeon that the durability of a surgical bioprosthesis is better than a TAVI valve. You just cannot. That's not a fair and balanced explanation to your patient. You need to be balanced, and this will definitely change the shared decision-making process, because as a patient, if you hear that the less invasive strategy also is associated with less structural valve degeneration, we all know what the patient will choose. That said, there was only follow-up up to 5 years. And we know that surgical bioprosthesis will start to degenerate at 8 years. So I think this extended follow-up to 10 years will be very important to see how this will evolve, and I think we will learn more and more about structural valve degeneration.
So how do you compare that then, Nicolas, to Partner 2, where you see the complete opposite? Is the difference in the valve arm, or is the difference in the surgical arm?
Well, it's very difficult to extrapolate because there was also a difference in definitions used, right? And the structural valve degeneration in the surgical arm was more or less the same here. It really was more structural valve degeneration in the TAVI arm in Partner. But again, you have to be very careful with extrapolation because the definitions were somewhat different.
Yeah, interesting. ADAPT-TAVR.
ADAPT-TAVR was another study in the TAVI scene from Korea, where they compared edoxaban versus DAPT, so aspirin and clopidogrel, in patients who did not have an informal indication for oral anticoagulant drug therapy after a TAVI procedure, so no AF patients. Patients the primary endpoint was HALT, leaflet thickening, but they also did MRIs of the brain at 6 months in order to see whether there were more new brain lesions with one regimen over the other. Turned out that there was no difference whatsoever between the two treatment arms, and we mean with that significant differences, because there was almost a 50% relative risk reduction in the incidence of leaflet thickening with edoxaban. And we're not surprised, obviously, because from registries and also the randomized data that we have from the low-risk Partner and the Evolut low-risk trials, it became clear that when patients take oral anticoagulant drug therapy, leaflet thickening is less common. So we're not surprised, and I think this is a sample size issue that the difference was not significant, because it was 18% in the control arm, which is in line with the literature, and single digit 9% in the edoxaban arm, also in line with the literature. So I think my conclusion would be, at the end of the day, that yes, if you would use edoxaban, you will see less leaflet thickening, but leaflet thickening has no clinical implication as far as we know today. And that's why you should not, as a clinician, you should not do follow-up with CT scans after TAVI and just give aspirin, because that was basically the missing link in this trial, because the control arm was on aspirin plus clopidogrel, which was again common regime in the time that patients were being enrolled for the study. Nowadays, we will only use aspirin and no longer clopidogrel, and that should have resulted in less bleedings than in the aspirin.
Exactly, yeah. So this actually made the potential difference in bleeding, of course, it mitigated the potential difference in bleeding risk.
Because now there was no penalty for edoxaban because clopidogrel was added to the aspirin. Yeah. Good.
All right.
The last one, as always, we should end with a renal denervation study. So, Joost, what happened at the ACC?
Yeah, fortunately also at the ACC this year, some interesting news in RDN. So in this case, Felix Mahfoud presented the 3-year findings of the Spiral HDN OnMed trial. So the pilot actually that was published a couple of years ago, showing a significant blood pressure lowering effect of RDN on top of at least 3 drugs in patients with therapy-resistant hypertension. So 7.5 millimeter difference in 24-hour mean ABPM in the RDN group in favor of the RDN group, which fueled, of course, a lot of debate as to whether these results were durable. And that, I think, is the interesting part. So that was what was presented now at ACC and published simultaneously in The Lancet, is that actually at 2 as well as 3 years, the delta in blood pressure difference remained, which is interesting, despite the fact that the average burden of antihypertensive drugs remained more or less similar in both treatment arms. So that, I think, attests to the durability of the therapy. I think that is point one I wanted to highlight. The second point I wanted to highlight is that this also puts in some nuances to the longer term data of, for instance, the off-med trials like Radiant Solo, in which the treatment delta, so the benefit of RDN actually mitigated at the longer term simply because of the fact drugs were simply added in these patients and into a greater extent in the sham arm as compared to the RDN treatment arm. Which is, of course, somewhat different in a study population consisting of patients with therapy-resistant hypertension who were already on a stable regimen of at least 3 different classes of antihypertensive drugs. So, in conclusion, very reassuring data attesting to the durability of the treatment of RDN.
And also, I think in line with your data from Erasmus?
Yeah. So one of our fellows presented that only very recently that indeed if you follow the patients, at least we treated here for therapy-resistant hypertension in Erasmus, the blood pressure lowering effect up to 5 years remained very stable and actually even increased a little bit along the course of the study, but again without a significant increase in antihypertensive therapy, which is completely in line with the findings of HDN OnMed. So with that, I think there will be more data on long-term on durability of RDN, but with the data we have thus far, it seems to be a very reassuring finding that this technology is durable.
All right, that wraps up the most important and most interesting late-breaking trials at ACC. Thank you very much, Joost, for the insights, and thank you all for joining us at the EMC wrap-up of ACC. We'll hope to see you again for the preview of EuroPCR a couple of weeks from now. Thank you. Have a good one.
Thank you for watching. Bye-bye.